CataractCoach.com. Welcome to our podcast, episode 4. This time I have a treat for you. We've got Tom Oetting, one of the premier cataract surgery teachers in all of the USA. He's an incredible guy. I've known for 20 years. I've learned so much from him, and I bet you'll learn a lot too. Our interview was fantastic. We talked for almost 2 hours, so you may want to download this on Apple, Spotify, or Google and listen to it while you drive to work or you exercise in the gym. But we had a fantastic time, and I learned even more great material from Tom Oetting. He's at University of Iowa. He's won their teaching award 5 times, the most ever in that department. He's even won the inaugural ASCRS Educators Award. He is a true cataract surgery educator, and hey, we love cataract surgery, so check it out. So I want to welcome you to our Cataract Coach podcast, episode 4 now. We've got Tom Oetting, a true leader in the cataract surgery education field. I've learned so much from Tom, and I think in this podcast you will too. So Tom, thank you for being here. I learned a lot from you.
Well, thank you, Devgan. First off, I have to say thank you on behalf of the zillions of fans of your videos. And as a fellow sort of video maker, I can't believe what you've done. I mean, the idea of producing a video every day for like 2,000 days in a row is unbelievable. I remember when I first started doing videos years ago, I would try to do one a week, and it was like, a 1-2 minute video a week, and you've put out like 2,000.
Come on it. Later this year we'll hit 2,000.
Yeah, it's close. But anyway, I just want you to know everybody's noticed, everybody's impressed, and on behalf of our residents and our crew at Iowa, we are big fans, and I'm honored to be able to talk to you. I've just really enjoyed our relationship over the years.
Oh, thank
I remember
you.
when I first met you at the FACO course in Harvard years ago. And I just thought, man, I wish I had some of his juice. I just wish I had a little bit. But anyway, congratulations.
You're too kind. Oh, thank you. My dad didn't raise any lazy kids. Ugly, yes, right here, but lazy, no.
That's good. Well, I sure appreciate being here. I saw your podcast with Dr. Osher, and
what an amazing guy.
Yeah. It's everyone should turn off this podcast with me on it and go watch that podcast.
Well, do that one
That's
first.
my advice.
Do that one first and then come back here.
Well, but anyway, thank you.
No, it's an absolute pleasure. So, what's telling about you is, like, your name on Facebook is cataract surgery. Like your Instagram, your this, everything is cataract surgery. You are as bananas about cataract surgery as I am, probably even more so. Why? Why do you love cataract so much?
Well, what's interesting is that one of the reasons I was able to get those particular handles is because I got involved so early.
Sure.
I heard, I got involved in YouTube before it was YouTube. It used to be called Google Video. And we would upload these videos, and honestly, it would take hours for the upload to occur. And it would get on, and then a real person would review it. And they would text me and say, we looked at your video. It looks like it's not porn or anything, whatever, and we'll play it. And it was crazy the early days before YouTube, and then of course when YouTube, when I guess Google purchased YouTube or however it worked, and so they got rid of these Google movies. But we were really early in that, and then Facebook. My kids turned me on to Facebook. My oldest son Drew. Turned me on to Facebook. He's now 32, so years and years ago when it was first coming out, and that's how I was able to get the cataract surgery, and then of course Instagram. We were on that early on,
so you're Twitter. You're an early adopter. Anything technology, you are in it.
Well, it seemed a perfect. A perfect thing for us. And you have to, of course, realize we're in the middle of nowhere in Iowa City. And we have to figure out ways to get our message out to the world. And the obvious way has always been publications, and a lot of our faculty here have done that. But this just seemed like such a perfect way for us to share what we're doing in a virtual way. And we also had some really good residents that pushed us really hard in this way. For example, I don't know if you know Andy Doan. You probably know Andy
Sure,
Doan.
Of course.
So Andy Doan was the resident of ours that started iRounds, which is a website that we're really proud of. And this was really early. I mean, when the first iRounds was on, I mean, you waited for the pictures to come before broadband and stuff.
For sure.
But
you also have greenhorns, cataract surgery for greenhorns. We've stolen that at UCLA for decades, 2 decades probably.
Well, yeah. So that was another sort of attempt at multimedia. And
so tell me what was Andy Doan doing with iRounds?
So Andy Doan was this amazing resident we had who realized the power of putting good content onto the internet.
Sure.
And he realized there was a lot of crummy stuff on the internet.
Sure.
And so basically, he really pushed us hard to not only put good content on, but to put content on that didn't require any sort of codes or sign-ins.
It's right there. It's free. It's available. Just have it.
And the beauty of that, especially with early Google, was that the Google crawler would come and hit iRounds and could get all over it and figure out what was going on. Whereas the Google crawler would come and it would hit like the Academy site or other people's sites. It's blocked
behind the login.
Couldn't get past the login, and so didn't know what was going on. And so we just shot up in all these Google searches, and so we realized that that this was an important way to sort of get our name out. But the other really cool idea that Andy had, and this is going to sound funny, but we originally, when we were putting out this content, we would have these links at the bottom where, let's say that we talked about plastic surgery, and one of the links would be Jeff Nerad's book on plastic surgery, which is a classic book, the Perquisites book. If somebody clicked on that link back in the old days and bought the book, iRounds would get $4.
Whoa! Yeah, the click through.
Just the click through, sort of the referring this person to there. Jeff Nerad, who wrote the book, got $3. and that's when the light bulb went on and said, "Oh, wait a minute! God, the content providers are totally getting screwed in this deal." So, and we realized the distribution was trivial, becoming more and more and more trivial.
Probably.
Sure. And the sort of palace guards that controlled content were less important.
Sure.
You kind of flattening of the world of make believe.
Just put it out there.
Yeah, and so basically, we started talking about bringing, sort of connecting the content creators to the content users, and Andy Doan was way ahead on this. And so what we did was, with iRounds, we started paying the residents like $100 to do it to produce a case for iRounds. And
our alumni, I'll take you up on that. Hello.
Yeah. Yeah, so well, you should. You've got we couldn't afford all your videos.
You paid me more than $100,000 for more than 1,000 videos. So
yeah, it's too much. It's too much. But we pay $100,000. $100 for a case, and then at least the resident who worked hard on this case could take his family out to
dinner,
Chick-fil-A. Yeah, somewhere. And so that was the very early sort of, to me, epiphany of the use of sort of virtual training and how it could benefit the University of Iowa, because we could become known for this. And our world of make believe, we're producing this content anyway. Our just like you, we're teaching and we're learning. And our job is really as professors in the university is to curate content, create content, judge content. Every now and then we invent something, but that's pretty rare. Usually we're sort of stealing other people's stuff and finding other stuff and sort of curating it. And so this was a way for us to do it. Now it sounds trivial now because it's 2023.
Sure.
But we're talking back in 1998 or something.
Yeah, it was amazing. It was a huge improvement. I mean, it was a way of getting the material out to the masses.
Yeah, so Andy Doan really helped us. He was one of the first people that helped us. And then we had a wave of residents sort of in the second wave post-broadband social media.
Sure.
And those were people like Dr. Glockenflecken,
Will
Flannery, Steve Christensen. I don't know if you know him.
Yeah, for sure.
Steve. And Lori Provencher. Those were three residents who were all together. in like one class.
Wow, what a powerhouse class.
Yeah, and so they were all together.
They were schooling you.
Oh, definitely they were. And really, Steve Christensen was the one that was pushing us the most to move to Twitter.
iSteve.com. He's fantastic.
Yeah, so iSteve got Lori and Glockenflecken started, and got me started on Twitter. Although I haven't used Twitter as much as Instagram, but I think the point is that there was this sort of second wave of the use of social media, and it partially came again because of our sort of position in the middle of nowhere in the United States, and we're trying to get attention to the stuff we're doing. We're not interested in getting paid for this. We're not interested in having ads on it.
You're doing it for the sake of learning.
We're just doing it. We're producing it. We want people to learn and share our stuff. So that's the if I have any secret to any success that I've had, it's listening to these amazing residents we've had that have come here, paying attention to them, and my children too, honestly, paying attention to them and saying, these things that are happening, we need to jump on it, and not be too slow. There's a tendency in academic places to be super slow, to catch on. And,
you guys are cutting it. I actually last week gave a lecture at the brand new UC Davis Shannon Eye Institute, beautiful facility, and I met the residency program director, Nandini Gandhi.
Oh yeah, wonderful lady.
She was amazing, and all she could say was what an incredible training program Iowa was, and how she's going to make UC Davis the next Iowa.
Well, she is wonderful. The thing, she's another great example. So when she was a resident with us, she told us that we need to get our act together in international ophthalmology. We need to have some opportunity.
Yeah, amazing.
And so, Dr. Carter, who's our chair, and I were like, well, okay, whatever. There's a lot of work to do here in Iowa. Why don't we just do that first? Kind of,
sure.
A little bit of resistance, and eventually we said, okay, we did it. And so she started this program that a lot of our residents have done, where during their chief year they can go off and do some international work. And it's really helped us quite a bit because we've gotten involved with Orbis.
Sure.
And if you want to know an organization that's just killing it in simulation training and sort of global educational training, it's Orbis. And so, but with that international thing got us a little bit of a visibility in the international world, which came from Nandini Gandhi, and then these other players that are gigantic in like Orbis said, hey, let's pay a little bit of attention to Iowa, and so anyway, I think you can't bring these amazing residents to your program and not pay attention to them.
Well, there's something about the Iowa program that seems like it's always on the cutting edge. So even way back when I'm residency class of 2000. I think you're residency class of 95.
Yeah.
So I'm 5 years behind you. But even when I was a resident applying, I applied in 1995 for residency that started in 97. I was the first program that went to like 4 years or integrated an internship. But Iowa's always been cutting edge. And there's some magic that you have in Iowa, in the middle of the country, in this small, tiny town, that you're able to succeed to a huge degree in residency programs. What is it about Iowa?
One of the really cool things, you're gonna think it sounds sappy, but one of the really cool things about Iowa are our patients.
Yeah, and I agree with you.
The reason this is so important is because we're asking our patients to contribute to the training of our residents.
Yes.
And this is something I know you're very aware of, and that is the fact that there is some trade-off where we're saying, hey, would you be willing to introduce yourself to a little bit of extra risk with the surgery?
Sure.
In exchange for that, we're going to offer these amazing residents that will work with you. And the question is, and this is what we ask our residents from day one, is how can you add value to that patient to make up for the extra risks that you bring to them when you're learning how to do surgery?
Oh, brilliant.
And we have to ask ourselves as faculty, are we doing everything we can to limit the risk of surgery with these trainees? Can we look these patients in the eye and say, yeah, this person's ready? And I really can. I mean, today, my experience was I had 3 different levels of residents I was with.
Okay.
So
PG what, 2, 3, 4?
2, 3, 4.
Yeah.
And so the PGY2 that I was with, amazing woman. All she did in the case was she folded the lens, she placed the lens in the eye. She folded the lens, then she did a little bit of irrigation aspiration of the cortical material that was teed up by the chief resident. It was like when your mom hands the jar to dad and it's already kind of loose. It was just like that.
So it's basically, that's the backing in thing that was kind of innovated there in Iowa 20 years ago.
Yeah, but we stole it from Utah.
Okay.
But yes. So
we all steal from each other.
Yeah, so she did the backing in thing, did a beautiful job, put the lens in, rotated the lens. It was a toric lens, rotated the lens proper position, and then put the moxifloxacin in at the end. So she did this very easy part of the case. Sure. Now, she's also been getting serious simulation training with Dr. Jackie Hogsdale, who's a real important name for you and others to remember. Jackie Hogsdale is just a superstar in simulation. So Jackie Hogsdale has this, and you can go on if you Google Iowa Wet Lab, you'll find this very structured training program that Dr. Hogsdale does in simulation. And so this woman had also done all the simulation work. So she had simulation work, she's doing parts of cases, so that's what she's doing as a very junior person. All right, then you bring in the PGY3. Now the PGY3 had a very simple case, right?
Okay.
Gigantic people. People so big it's bigger than an eye. Just huge people. We had a beautiful retrobulbar block. Slightly controversial maybe to do it or not, but in my experience, the retrobulbar block's a beautiful thing for training.
I agree with you. For the residents, first at least 50, if not 100 cases, do the block, make life easy. I agree with you 100%.
Yeah. You get good prolapse. The patient doesn't move. The patient's happy. And a lot of times, if you ask the patient, do that, if you did one eye one way and one the other, a lot of times they like the retrobulbar better. But anyway, so we did a retrobulbar block. She had a very simple case. Beautiful. Now she didn't use both hands, right? So she just used one hand, and I'm using the paracentesis is all me.
Oh, okay. How do you operate with one hand?
So I'm the second hand.
Okay.
And so this is another important concept with training, and that is that you can't use both hands at the very beginning.
Yeah.
You have to sort of work the second hand in, and so for the first. You gotta crawl before you can walk. Yeah, and basically, as you know so well from all your teaching, you can do almost the entire case with the paracentesis.
Oh, yeah.
I mean, if you can just hold that phaco steady in the middle of the eye, you can do the rest with the paracentesis.
Funny because it's true.
Yeah, it's funny because it's true. So this woman. Did the case with one hand, did a beautiful job, but before she had done this is an interesting thing that we do here, and I know Tim Johnson
for sure.
We're so excited. I just want to tell the world that Dr. Devgan is coming to Iowa City for our big annual conference, and we asked Dr. Johnson, who's retiring, what's his dream of speakers. And it was to get you to come, and so we're honored.
Oh my God, I'm honored. Are you kidding me? The honor is mine. I will be there in June. Anyone who's listening, please come join us.
So anyway, Dr. Johnson is a wonderful teacher. He's retiring, and what he's specialized in is what we call deliberate practice of the rexus. And so this same woman I was telling you about, who did this simple case,
sure,
had done about 100 capsular rexuses with Dr. Johnson.
Oh, nice.
And so what he does is all they do is the capsular rexus. So again, it's parts of cases. And she's had tremendous simulation training with Dr. Hogsdale.
Like that's the IC simulator?
The IC is probably the best way to do that. And so she's done simulating training, and Dr. Johnson, it's crazy he does this, but he does high volume surgery, but they come in, they just do the rexus, and then he does the rest of the case. And for him, it's like it adds some fun to it.
Sure.
Because, he's like you. He's done a zillion cases. He wants something interesting. So anyway, so this woman had done deliberate practice of the rexus, simulation. She'd done the backing in, Now she's done these simple cases with one hand.
Yep.
And then the third resident that I had today was a chief resident. So this is a woman who's, you got 100 cases under her belt.
Nice.
She's very experienced. She had some tough cases today, and she did the whole case herself, both hands. She's chopping pretty well, and she's working on some fine tunes. But to me, the way to sort of work on cataract surgery training is to have a very structured and deliberate plan.
Sure.
And then pay attention to where people are and work on what they need to work on. Anyway, today was just a great day to sort of have, before I talk to you, to sort of talk about these various levels of training.
So can any resident do it? So I'm of the feeling or the philosophy that if anyone desires it, they can achieve it. Like if I say, I'll give you a king's fortune if you can sing 10 basketball free throws in a row. I don't care if you're where you are on the spectrum. You can put in the hours, you can make it happen. So I kind of believe the same with cataract surgery. Maybe some people have a little bit of advantage over the others, but if you put in the hours, everyone can achieve it. Are you the same philosophy?
We've never had a resident in all the years I've been here.
Wow, and you're no spring chicken, so that's been
exactly. It's a long time. So I've been in this business
30
since,
years.
Since been faculty since '97, and I was a resident before that since '92. So 30 years. And so I think the answer to your question is yes. There are some interesting variations in learning curve.
Sure.
And that's some of the fun for me is to sort of pay attention to the variations in learning curve. There's some people that are very good at the beginning and then just are flat.
Yeah.
And there's some people that are just that struggle at first and then go. Choo!
It's a different curve for everyone. There's no one set curve.
I've noticed that left-handed people are really good with their second hand.
Of course. Especially if they do phaco probe right hand, chopper left hand. The chopper does, as you said earlier in this conversation, the chopper does all the work. If you're a lefty and you're starting off, please put the phaco probe in your right hand. You will be amazing.
Well, even if you put it in your left hand, their right hand is so good because they've been forced to do so much stuff.
Yeah,
with
for
their
sure, for sure.
So I think the learning curve for lefties is often funny. Like at first, it's kind of difficult, partially because the teacher doesn't know what to do, partially because the like you say the resident's not sure what hand to do with what thing. But one of the fun things about doing all these years is watching the joy of learning it with time.
Yeah, for sure.
And then from my point of view, is trying to figure out tricks to make it safe as possible for our precious patients who have agreed to this bargain.
Yeah.
And to get back to this trade-off.
Yeah.
There is no doubt in my mind, that our residents add so much value to our patients that it is worth it to them. There's so many times when our patients have come in and had seen several other really good ophthalmologists, and our resident figured out what was going on. Yeah. Because they had time, desire. They had just been through all the subspecialties. They just read the basic science manual.
The BCSC is fresh in their mind, and they're enthusiastic and energetic.
Yeah, they're not whatever I'm thinking about, whatever happened at home or how hungry I am or whatever BS I'm thinking about. They're coming in saying, I'm going to figure out what's going on because this is. And so the trade-off, I think, is worth it to our patients because there's value added by our residents that makes it worth the risk. The second reason I think I was really cool is, we're like the only show in town. You've got this tremendous pressure in LA, right? You've got, 2 or 3 training programs. Yeah. You've got thousands of unbelievable surgeons around you.
Yeah, for sure.
Now, we've got really good surgeons around us that most of them we trained. But we also have there's no other training program in Iowa, and so when patients come to Iowa City, this is their program. If they read about in the paper that Dr. Devgan's coming to Iowa City, they're saying they're coming to my program.
Sure,
Dr. Devgan's coming to Iowa City. It's their program. So these are their residents, and so they have bought into the whole idea, and that's honestly our super secret weapon. Is the
patients?
Patients.
Yeah.
And we don't have this place where people aren't special, and residents go practice on them. we don't have. There's no difference, and so that makes us all very careful about being, getting people ready.
For sure. No, I agree.
Anyway, so I appreciate you asking the question.
No, I agree 100%. I actually retired after 22 years of teaching residents. Just retired a few months ago. The county hospital patients here in LA are the sweetest people I've met in my life. They're so easygoing, so appreciative, so thankful, the biggest hearts. In fact, I still miss them all the time. The patients were just amazing. So I think, we're put in a position of like great honor and responsibility and privilege to be able to take care of those patients and really give them a rest. So I did exactly what you said. When I was with my residents at the county hospital, I brought my absolute best. Every single surgery we did, I want to give that patient with the resident the same high level of care that I want from my own eyes or my family's eyes in my private clinic in Beverly Hills.
I mean, going to the county hospital and having Dr. Devgan do your surgery with the residents is like going to some random food truck and seeing Chef Bobby Flay.
Oh, I love watching.
It's ridiculous.
I love watching him on the Food Network, so I am honored when you say that. He is amazing. But no,
he is amazing.
It was an absolute pleasure. It was an absolute pleasure. The sweetest patients, most thankful, and we got to do. Another thing is the most complex cases. I sometimes joke that in my private practice, I specialize in 2+ NS.
Yeah.
Whereas you go to the county hospital, this is where we do the very complex cases, the triples. We do the sutured in IOLs, the Yamanes, the iris, the pupilloplasty, the DSEC, we do everything there. And so that was just to help patients who are of that much need. Not your guy who's just, 20/50 vision, 2+ NS. It's really a pleasure.
Yeah.
And makes for some great videos.
Well, it's good videos. It's good extreme experience in learning. But anyway, I know that was hard for you to juggle all that stuff to have to do. I can understand why you had to eventually give it up.
Well, for me, honestly, it was just switching gears. To be very frank, I posted recently about defining success. And at the beginning of my career, I defined success differently. I defined success as like, surgical volume and income and job title. It was important for me at the time, like I had to make full professor by 44, and I achieved those milestones, but it was fantastic. But it's time, like I changed what I define as success now. I have a much bigger part of the pie for health and relationships and happiness and enjoyment. And, for me at this stage, after age 50, the piece of the pie devoted to like surgical volume and job titles is a little bit less. So, and I think that's normal. I think we all change gears when it comes to that. And I just saw it as an opportunity that, it's time to change gears. I don't want to be that one guy who sits there as chief of that big county hospital for multiple decades, even when I'm like, coming in with a wheelchair or a crane or a cane. So let me just pass the baton when I'm at the peak. So like you, I know you won the teaching award 5 times at Iowa. I won it 5 times at UCLA. And so at my peak, I said, let me just be gracious and bow out and pass the baton to the next generation of 30-something-year-olds who want to now ascend the throne.
Yeah, I think you're absolutely right. And the other thing I think that's important about that is that there is these phases you go through in life, and there's this period of time when you kind of have to push and you have to juggle everything, and you just have to do it. You have to prove you can do it, and then there's this period of time when sometime around 50 or so, when you get a lot happier, life gets a lot better.
You become an empty nester.
Become an empty nester. You just take joy in simple things, and I love going to Costco every week. The highlight of my week is oftentimes going to Costco. Yes, it's just simple things like that. And so I think that what I always tell these poor folks that are like 40 or 35. I mean, that is a tough time.
That's a rough time.
God, it's just. You got kids. You don't know where you are going to be in life. You're struggling. You're juggling. Your parents are sick. All these things that are going on, and it's an impossible time. And the only thing you can tell them is, there's good times ahead.
Hang in there. Don't give up hope.
Yeah, it's good times.
Yeah, it's a tough balance there. It really is, and I think I struggled a lot in my 30s and 40s, especially in my 30s. I had no concept of balance in my life. Like I would do clinic 5 days a week, plus Saturday. So my 5 days a week was Monday through Friday. Obviously, starting as you know, I start early before the sun's up. Like even now, I'm in my surgery center by 5 a.m. But I'd also do a night clinic Tuesdays and Thursdays till 8 p.m. And I did a Saturday quote morning clinic that was supposed to finish like at 1 p.m., which always ran to like 3 or 4 p.m. Like
right.
I had I was so imbalanced in my priorities that I have a guilt about it, and I want to like teach other people like, please, these are mistakes I've made. Learn from my mistakes.
It's hard though because on the other hand, you're so well established and you've done so much. It's easy to say that, right? So
Sure.
And that's the hard thing when you're talking to young people. But anyway, to me the most important thing is it gets better.
Sure.
And things are. Everyone gets happier, when they're like, of course I'm like 10 years ahead of you or something, but this phase of life from like, I don't know, 50 to 70, everybody loves it.
Yeah.
Everybody's happy, enjoying it. And, but anyway, from my point of view here, it's so wonderful to be with these amazing young residents and medical students and young faculty now.
Sure.
The faculty are young to me now. Because they keep you interested and excited and
keep you on your toes in the OR.
Oh yeah. Well, you know this as well as anybody, but the variability that are introduced by individual residents
Sure.
being with you gives you so much experience so fast.
Yes.
That if you want to shoot your learning curve through the roof, take a job as a young faculty teaching.
It's funny you say that. I did surgery recently for an ophthalmologist. Flew in from out of town. I did surgery. And I said, of all the people, why did you choose me? You could have chosen anyone in your hometown. There are a lot of great cataract surgeons across the country. He says, obviously I've seen videos you operate. I think I like the way you operate. But he says, more importantly, I know you've been teaching residents for 20 years. So in that rare chance that things go south, you actually know how to finish the case.
Yes. Well, that's right. I mean, it's funny because at first it's when you're in the teaching job, that sort of introduction of variability is really hard because you're going to get 2 or 3 years where you're going to learn everything.
Yeah.
And then, but once you get past that, and I think it's important to develop faculty through that point and nurture people that are in those jobs so that they stay with you. But once you get past that point, I mean, you've kind of seen everything. And you've seen stuff that you wouldn't see in your own practice for years.
Yes.
So whether that's good or bad, I don't know. But I think to me the most important thing though is just being with young people is fun and watching them grow is fun. And
how do you help a young resident get past that like initial frustration barrier? Like they're just starting off, maybe the first 10, 20 cases. Their hands aren't doing what their brain tells them to do. They're just frustrated. That's a frustration barrier. How do you get them past that frustration barrier?
Well, I mean, I think you first off you need to let them know that they're not the first person to be in that boat.
Sure.
So, from their point of view, they're thinking, "Oh my God, I chose the wrong field," or "Oh my God, I've got a wife and kids at home, or I've got a husband and kids at home,
Sure.
or something," and I'm not going to be able to feed them, and I made a huge mistake, and so that's what they're thinking. So they need to know that that the learning curve goes like this,
Sure.
It sort of bobbles up and down. And so the second thing is, I think it's you present things they can excel at, and you don't push them too hard. I think it's important to, for example, I always want to be the one sitting in the driver's seat when the lens falls.
Sure.
So I know there's trouble, right? I know that we're in trouble.
Sure.
And so I take over, and then the lens drops when I'm there because little things. If you can somehow if you can somehow minimize the impact of those problems, so that they don't ruminate over it.
It doesn't affect their psyche.
Yeah, and then they don't go backwards as much. Everybody goes back a little bit when they have a complication. Everybody.
Sure.
does.
Oh, for sure. Even now.
Probably even now. For me, I think about it, and that's why you get a reasonable wage when you're a surgeon, right? I mean, because you think about it the night before, you think about it the night after. I mean, it's something. And but I think that I always say it's better to do part of a good case than all of a bad case. And I think
I like that. Better to do part of a good case than all of a bad case.
Yeah, because it can set you back so much.
I love that.
And so anyway, I when I first started, I didn't understand this as a teacher, and I would let these sort of trainee get themselves in increasing trouble.
Sure.
Partially because I wasn't as good of myself at getting out of trouble. To be honest with you,
of course.
But mainly because I just didn't understand this concept, and so now the little micro interventions the entire time during surgery is my norm, and so that paracentesis and I are like connected. I'm all over.
I often make an extra para. If the
I do too. Yeah.
If you're doing a left eye, yeah, exactly. And the resident's right-handed, so they have a para that's too far away from you. I'll make an extra para.
Oh, you've got to. I totally agree with you. I think that's we need to tell the teaching world that's just mandatory because, and sometimes I'll make two paracenteses if it's a funny angle.
Sure.
But anyway, the two extra paracenteses. But I think sort of the idea of intervening to keep things moving along so that then their confidence builds, because it takes like at least 50 cases before you even figure out the AP depth.
Yes. Yeah, absolutely. How to pivot in the incision, how to float in the incision.
Yeah, and one of the great things about the thing I told you Dr. Johnson did with that sort of deliberate practice of the rhexis is in a relatively safe situation with the rhexis.
Sure.
They learn a lot about that sort of pivoting.
Yeah.
He calls it oar locking, whatever. He's got a lot of terms for it.
Oar locking. Absolutely, I do the same thing.
And so now you could argue it's the riskiest part of the procedure because if the rhexis goes bad, but Tim just turns them off in a second.
Of course.
And he takes over. And again, I think from Tim's point of view, it was fun for him all those years to do that. And then what Tim would do is he would collect just those videotapes, and at the end of the day, he would go over those videotapes with the residents and say, here's what you're doing wrong. But I think the sort of simulation, parts of cases, not using both hands at first,
backing into cases, I like that.
Backing into cases, using easy cases first, using the retrobulbar block first. And then also what Dr. Hogsdale does is she sprinkles in longitudinal wet lab stuff.
Oh, nice. Throughout. Oh, smart.
Because of the simulated eyes, it's so easy to do that now. And so that's our strategy. And everybody's not the same, but it works well. And if you can keep people's confidence up and not set them back, then they have less of that problem. I think one of the biggest problems, and you've alluded to this before, this is one of the niches that you're beautifully filling with your videos, is the post-residency training.
Yeah.
Because
you learn more in your first few years of practice than you did in the previous 10.
Yes, and there's this classic paper I suggest all people in academic cataract read, that by Campbell. He's a Canadian fellow who's done a bunch of these big studies. And basically what he looked at was the 10 years after residency, what the learning curve looks like.
Oh, tell me. I don't know.
And so basically it's like there's like a 10% improvement per year in terms of the sentinel events, which are basically capsule tears and vitreous loss, over those 10 years. And so there's nothing magical about finishing the residency.
Yeah.
If anything, a lot of times people are maybe a little worse right after the residency because they're not watched as closely.
Sure.
But there's this learning that it continues, and one of our jobs, I think, is to try to figure out ways to help people with that period of time.
To keep learning, you've got to learn. Got to learn it throughout your career.
And that's one of the things that your videos, of course, the Academy's aimed at that. There's a lot of emphasis now, but when you and I came out of residency, there was nothing.
Yeah.
There was this void.
Yep.
and probably that deficit is possibly that's the chip on your shoulder that helped the world get all these videos of yours. I don't know, but but anyway, the other way of looking at that is if you say, would you hesitate to have a young faculty do a cataract surgery on one of your patients in your academic center? The answer is no. Of course, my young faculty can do cataracts,
Sure.
right? But there's not that much difference between a young faculty and a chief resident if you look at that study.
A couple of years.
I mean, it's just, a little bit better.
10-20% from the study.
And so it's a continuum, right?
Yeah.
And so and that's the argument that I use for why we shouldn't make it it's not such a dramatic cutoff. It's a continuum of skill acquisition, and honestly there are. I've been doing this for years. I've got a lot of surgeon under my belt, but I'm not like, I don't know, the good example, probably you're a good example, somebody that does 50 a week. Like Jason Jones is a good example.
Sure.
here around up. Jason does like 50 cataracts a week himself.
Sure.
And so, I'm really good at like being a driver's ed instructor and getting people to the point where they can go off and one day be like Jason Jones. But there's a continuum within cataract surgeons. There's somebody like that's done that many, and so I think that's the way you think about it. You have to think about getting to a reasonable level of safety.
Sure.
And anyway, so that's kind of the business we're in, and I've been doing all these years.
Can I ask you your opinion on something? I get a lot of emails every day from people who watch CataractCoach. I probably get 5 to 10 videos submitted to me a day, but I probably get another 10 to 15 emails a day asking for advice. And one that came through recently, I want to read the email to you and take your advice. I haven't replied yet. I was like, you know what? I know who to ask this question to. So here's the question. I'm going to read it exactly.
Okay.
From a CataractCoach fan, he or she says, unknown doctor says, I got very poor surgical exposure during my residency because of COVID. Residency year 2018 to 2021. Now I'm already 32 years old. It's been a year since I performed cataract surgery. I did around 100 cases during training, but I don't have enough confidence and I'm scared that I'm not going to be able to perform cataract surgery independently. What's going to be my future because of my weak skills? What should I do? It takes me currently more than 45 minutes to an hour to complete a routine cataract case. Please help me.
Yeah.
That's a tough situation, and I know you're going to have a great answer.
Well, it's a tough situation for a variety of reasons. I think for one reason, because this doctor has lost their confidence.
Sure.
And is second guessing themselves, and that's hard. And I think the other reason is that he or she is second guessing themselves more than usual. But everybody, to a certain extent, has that feeling when they come out, that they're not quite ready or they don't know everything. Just like we were talking earlier, we weren't really fully prepared to. So I think the one thing to try to remember is that you're not alone in this, and that discussing with your peers how they feel about it and sort of where they are would be helpful. I think they need a coach of some kind.
Like a mentor, a mentor in the community, a senior partner in a group. What do you think?
Yes, and I think if they said to their partners, if they have partners, hey, can we work out some deal like this? Can I come to the OR with you, and maybe do part of the case? Just the easy part. Work together with you. Could you come to the OR with me? And watch me and give me tips on how to work faster. In other words, admit the fact that you want to get better and want help, and probably that doctor would say, if they're not too busy, if it was, they probably would be slightly honored and want to help, and especially if there was some reason why there was some vestment of interest, like for example, they were your young partner or something like that. So I would consider doing that. After you're done in the OR, each day, I would get some semis and just do stuff.
Yeah.
Just get your hands working. And so even if it's just sutures, I would do that. I would have some semis, either Phillips eyes I like, or Simul-Eyes, or Kitaro eyes, or Bianco eyes. All those eyes are really good, and then work on something.
But just get your hands moving under the microscope.
Yeah.
Even if it's just tenonylon all day, it's okay.
Yeah. And so what I probably would do if you're trying to work on basic cataract skills is go to the Craig Phillips eyes in England and get a PS12 eye or a PS13 eye, and those are the eyes that are the least expensive eyes and the best eyes for practicing phaco, in my opinion.
Sure.
And then just at the end of your day, get like 10 of those. It'll cost you $100. And just crank through those 10. Boom, boom, boom. And use the equipment in the OR. There's nothing wrong with it because there's no cadaver products. There's no animal products. So just use those semis in your OR at the end of the day or at the end of your partner's day. So you use their equipment, their phaco machine and stuff that's already set up so the chief nurse can't get too mad at you about doing it. But they will. They're not going to like it. They're going to find a reason it's not good. But what I always tell them when during COVID we did a lot of practice in the OR, and I would tell them, that don't you want us to be good, or if it was your grandfather coming in next week, would you want me to practice?
Right.
So just use proper gilt. Tell them that just use like the JCAO, what is it? The JCHO or whatever that inspection group. Has told you that you're supposed to use simulation, and they'll say, "Oh, okay." They won't look it up. Or tell them the GME is required. Just make up some acronym and just say it's required. But anyway, but I think if you could do parts of cases, if you could get a support network to help you know that you're not alone, if you could use semis at the end of the day with your equipment, that would be useful. Only do easy cases. This is not the time to be the hero.
Should you maybe start back in things? Maybe start doing like pterygia first.
Yes. The simplest stuff you can find first, but don't take on tough cases. Send those to other people. This is not the time to take on tough cases. And then usually, if the case takes 45 minutes, it's almost always giant delays between things.
Like what? What do you mean?
Like if you look at a video of his case or her case,
sure,
more than likely there's a lot of gaps between things. Like there's a groove and then there's a delay, and there's a groove and there's a delay. But it's not that you're actually moving slower. It's that there's these things you're thinking about.
So you're ruminating too much. All those delays add up to like wasting time. Because
you just know what you're doing. Boom, 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 boom. And so I think. Even if all you do is think about the case and you go through the case, this is what I'm doing, this is what I'm doing, this is what I'm doing. I'm going to watch a video. This is what I'm doing, this is what I'm doing, this is what I'm doing. It's not always great to watch a superstar 3-minute video. Maybe watch a more routine video.
I have a whole section of just resident cases on Cataract Coach.
Those are perfect
cases.
Yeah, you've got some like 50 cases in, 100 cases in kind of cases. Yeah. Watch some of those cases, and usually those are like 10-minute cases, 15-minute cases, or something like that, which is a reasonable goal. So I would do that. But anyway, that's what I would do.
But it's going to take work. This is not going to be easy. This is you got to really put in the effort. This is not going to be this is a big challenge, but you can do it. It's just going to take enthusiasm, the right attitude, and hard work.
The thing to remember, I think, is when I came out of residency, I'd only done like 10 phacos.
What was that? I did 170.
Yeah, so I only done 10. Yeah. I did like 150 extra caps.
Oh, I only did about 20 of those.
But I was at the transition.
Yeah, you were the border.
Yeah, I was right at the border. And I'd actually done more buckles than phacos. Phacos to me, when I got into practice, phacos were like, oh my gosh. And so I had to do some of these things we're talking about with a partner that I joined who was ahead of me in that area. So I think it's not impossible to do this. And there's a lot of older guys that learn phaco or gals that learn phaco on their own. So it can be done. But we're so lucky now compared to, even 5 years ago, the semis weren't very good. And even 5 years ago, there was very little videos on there. There's nothing like we have now online, especially because of you. So I think this person has all the tools. They should not give up on ophthalmology. They should, but they should do it in the way we talked about. And they are not alone. I bet you might get some emails from other people saying, "Hey, I'm in the same boat," or anyway.
I may have to clip this video segment and make a separate video of anyone who's having this issue, please watch this segment.
Well, yeah, I'm sure it's common.
Yeah,
I'm sure it's common.
This question also reminds me a little bit of something that I've suffered through a little bit throughout the years, which is imposter syndrome. Why is it that's such normal human nature to have that imposter syndrome, to think I don't belong here? Oh my God, what am I doing here? People are gonna, what is it about human nature? Do we all feel this way?
But I think it would be sad if you didn't push yourself to the point that you felt that.
Sure.
Because if you're only doing what you're comfortable doing, to a certain extent, you're in trouble. Now what you're comfortable probably in every single kind of encounter in cataract surgery, but you may not have been super comfortable with how to do videos or maybe how to do audio for this thing we're doing right now, and so
you learn.
You learn, and so but at first, when you're doing podcasts, you're saying, well, I'm kind of an imposter in podcasts because there's always somebody else that's slightly better. So I think the way to think about imposter syndrome in my mind is that of course you have that.
Sure.
Who doesn't have that?
Yeah.
And you just have to sort of move on and realize that it's a good thing to have that feeling and it's a chip on your shoulder that's productive and
I actually do have notes about a clinical case that I want to ask you about later. Literally a case that I have coming up, but I was like, you know what? I know who to ask this question to.
All right.
So we'll get to that a little bit later. But no, I think these are all very important points. I mean, we continue to learn throughout our careers. I mean, that was the big surprise to me. When do you tell residents, when do you spring the residents the truth that, hey, what we teach in residency is just the foundation. You're going to keep learning for the next 30, 40 years of your career. I mean, that to me was a different mindset. I was very naive as a resident. I thought two things that were very naive that you're going to laugh at. Number one, I thought when I was a senior resident, I can't wait till I'm in private practice. It'll be so much easier. Oh my God.
Right.
The second naive thing that I said is well, now that I finished residency, I know everything there is about ophthalmic surgery.
Right. Sorry.
But then reality hits you wait a minute. Oh my goodness, I have been wrong about both.
Well, I mean, we were talking to our, we were having sort of a bogus dinner last night with our PGY2s because the risky time for PGY2 residents is halfway into their residency. So that is when the most sort of dip occurs.
Why is that?
Well, I think it's partially because internship in ophthalmology, at least, is a year where you're sort of learning how to be a doctor, but it doesn't have much to do with your future.
Sure.
And then about 6 months into the ophthalmology part of the residency is a weird time because number one, you're saying, oh my God, I've been doing this for 6 months and I'm still not sure what I'm doing.
Yeah.
And I'm like the only ophthalmologist in the entire hospital. And all of this is on my shoulders, and I'm here all by myself in the middle of the night, so that's kind of a bummer. And you're not doing much surgery, and you see your colleagues that are operating, and they seem so fun and having so much. And then you also see your internal medicine colleagues that you were just with.
Yeah.
And now they're wearing longer coats, and they're hanging out in the coffee bar. And they're hugging each other and stuff, and you're just running around with your indirect in your hand, and a bunch of lenses. So I think it's just a really common downtime. But so we were talking to them, it was a bogus excuse to go out to dinner, but we were trying to.
Hey, I'll take it.
Yeah, it's
when I come to Iowa in June, I'll take any excuse you want. Let's go out to eat.
Well, we're excited about it. We're really excited about the opportunity to take. To go out with the residents to go out. Everybody wants to go. The only problem we're going to have is who gets to go. But the thing that's striking is that actually the chief residents work much worse hours. The PGY4s work much worse hours than the PGY2s.
Sure. Oh, the trauma call.
they're on call all the time. They're operating all the time. They're up late at night seeing post-ops, pre-ops. They're doing all this, but they love their job because they have more control.
Sure.
They're doing the stuff that they're intended to do. They get more respect. They're getting more direct. They're more directly in line with the sort of process of taking care of the patient. And so this burnout sort of thing is more complicated than just hours. Now, similarly, there's a lot of faculty, like for example, Culver Bolt, who I've worked with for years. This really wonderful retina specialist. His hours are worse than any resident's hours.
That's because those retina people are on the extreme.
I mean, he works like 100-hour weeks. He doesn't get. I remember thinking how funny it was when we would worry about the resident work hours when they were with him. It's like, well, what about him, man? Nobody cares about his work hours.
That's too funny.
But the truth of the matter is, Culver Bolt, he's got control. If he wants to go home for dinner, he can go home for dinner. If he wants to fly to Paris, he can fly to Paris.
Sure.
He's got control, and so he amazingly doesn't appear to be burned out at all. It's crazy. So I think this burnout thing has a lot to do with other factors, and I think one of the biggest ones is control of your time, and then feeling. The other interesting thing about burnout is we'll send residents overseas, and they'll go overseas and they'll come back and say, Tom, I did 100 cases that week, and we worked and saw patients from 7 a.m. until 10 at night, and it was the greatest thing in the world. And I said, I say to them, well, we can do that at the VA.
They're like, no.
No, that's different, because they made the decision to do it, right?
Of course,
and they saw the. But anyway, so I think I think in ophthalmology, at least, if we can just be aware that, at least for our trainees, that to give them a little bit of control.
There is some balance. I think we're much better now than we were decades ago. Is the work-life balance during residency. At UCLA, when I was a resident, we took in-house call for at least the first year. I mean, sleep in the hospital, and we used to take it. Every fourth night you stay in the hospital, but we didn't want to be on call every fourth night, so we just changed our schedule so that each PGY2 we just stay in the hospital for a week straight every month.
Yeah.
And so I think, luckily, we've moved away from that, and I think the residency programs have figured out that maybe that's not the best idea. But how do you manage work-life balance? I know you work very hard too. You're very dedicated to your craft. How do you figure all that out?
Well, I mean, I think just like you, when I was in that 35 to 45 phase, I worked too hard. I spent too much time here. I was in charge of the VA. I was in charge of the residency. I had 5 clinical days a week, and
busy.
I staffed a lot of. I'd staffed probably 20 resident cataracts a week. It was a busy time, and I did most of the writing, talk prep, sort of stuff on the weekends and nights, and I don't know. I could have done a better job with that, with my family. I was lucky that I was really lucky that my wife, who's a pediatrician, made the active decision to slow down her practice then.
Sure.
Now I will say this, that when I look at my wife who slowed her practice down, she looks like 20 years younger than me. We're the same age. And she's like, oh, go. And I'm like, halfway dead, And so I do think she got the last laugh on the whole situation. But anyway, so I think.
Have you changed your day now? Have you changed your work-life balance now? Is it any different?
It's I recently Dr. Pavi Kemp, who you probably know her. She's taken over as the residency director. So that's been a big change just a few months ago, and that's been the biggest change for me so far. Is just less fires.
Sure.
And any time you take on some role like that, there's always the inherent fires that you have. So
now that's the pleasure of passing the baton to someone who's a generation younger. That's fantastic.
Well, yeah, I mean, it's just like you said, it's so important to do that before they tell you to do it.
Yes, exactly.
There was a good friend of mine who's a residency program director here who got told to do it, And I was on this committee and watching this go on and thinking, oh my God, this guy's doing a great job, and now he's being told. And that's when I made the decision. I said, I'm gonna do this before I get told. And
well, I did the same thing. I mean, I saw people that one side admired for many years ago, but then now they're really, they really ought to just consider pulling back a little bit or passing the baton. And I wanted to be at the peak, I can achieve no more. Let me not retire on the downswing. Let me retire at the peak. So it was a little young. I did retire from academia at 52, but you know what? I'll take it.
Well, I mean, it's in some ways it's a great time to do it because you've got a lot of time to do another thing.
Sure.
But the other thing that you're doing is you've got your own little university. You've got this virtual university going.
Sure.
And so you don't really need anybody's opinion about what's good or not good or what should be done or shouldn't be done. So I think
even better, I'm in the public eye. I'll post something wrong in one of the videos. I had something recently where I misspoke. It was a radial keratotomy video, and I said in the video, we may overestimate the power of the cornea, and therefore I said something backwards.
Yeah.
No, I actually said I said we'll underestimate the power of the cornea and put in a higher power lens, and then the guy was like, no. But in RK eyes, you're doing the opposite. I'm like, oh, thank you for correcting me. But making a video every day, I can't have 100% perfection. So I live in the public eye, and I'm so thankful when people correct me. So if you see me say something wrong in a video, please put a comment. I will thank you.
Well, I've learned so much from posted videos. I'm sure you have too.
Sure.
It really becomes a collective effort to a certain extent, especially if you put a video out of a procedure that you're on the early stage of your learning curve.
Sure. Like my DMEC videos.
Yeah. Well, yeah, DMEC's probably a great example of something that you learned on the fly. Now, I've never done a DMEC before, but I'm certain you weren't trained to do that as a resident.
Oh, it didn't exist then. But you know what I did? I did something very smart. I learned from people who are far better than me. I learned from Peter Veldman, University of Chicago. What an amazing superstar. And then Martin Diersheimer from Austria, who's like the godfather of this. And so what I did for both of them, I said, hey, can I, for Veldman, I said, you have a bunch of little clips online, can I put them all together in a video and put on CataractCoach? And by doing that, I just studied his videos. I must have watched them 50 times before my first case. That's what I put up. That video of how to handle the graft in any configuration. And then I put up a few of my own DMECs that I did with the residents. And then Diersheimer was like, oh, I can give you some more pearls. I'm like, please do. So I learned oftentimes far more than I contribute.
Yes, I'm sure you do. And because you're sort of, curating this, bringing it together. Anyway, I think it's also important for people to know that a lot of stuff you learn later, like a good example is MIGS, right? So for you and me, MIGS is something
that didn't
exist, and it was really nowhere near the turf of the typical glaucoma surgeon.
Sure.
Right? They don't usually operate in that area.
Sure.
So it was almost like everybody was Lewis and Clark, right?
Yeah,
everybody was
a good way of putting
discovering this new turf. Now, there was a few people that had looked at it a lot, like Lee Allward, my colleague here, that did gonioscopy.org. But the point is that when we made the move to MIGS, the cataract surgeons really had just as much experience in that area as the glaucoma surgeons.
Sure.
They didn't have as much experience maybe with the complications of it, but they did with it. And so, I always tell the residents, that, when we started doing these and staffing these, that, the tendency sometimes is to say it's glaucoma, therefore it needs to be a glaucoma specialist, but really the skill set to do that is maybe a little bit more like the kinds of things that you do when you suture lenses and you suture irises and stuff. And so, not to be scared of it, not to think it belongs to somebody else.
Absolutely. I think you need to have that wide spectrum mentality of doing a very wide spectrum of care, so you can help the most patients. At the county hospital, for 22 years when I was there with the residents, there were years that I did 50 or more Ahmed valves a year with the residents. So I'm not a glaucoma specialist per se, but boy, do we have a tremendous amount of NVG at the county hospitals. Neovascular glaucoma is like something in the water there.
Yeah. Well, you were there doing it. Nobody else was there, right? So thank goodness you went there and you did the job. And it was the sort of scaling down of what's expected has been a dramatic thing. But I do think that as these new procedures come, there's going to be something new for our residents as they come out, and it may be a whole new way to do removal of cataract, like femto, sort of. And the question is going to be, are you flexible enough and ready enough to move into that and not say this is not what I did as a resident. And I think the important thing for us to do is just to show the set of things that we had to learn, and how did we do it?
Yeah.
How did you get to that point? And there's a great. Do you know Sarah Borzog?
Yes, actually, I have a couple of her videos on CataractCoach. She's now in Maine, if I'm correct.
Correct. She did this great video on how on learning Yamini.
Yeah.
It's like an old timey silent movie. Anyway, I'm glad you know her. I think I just love this video. It's so funny, and it just goes over sort of some of the things you're talking about how to learn a technique.
Yeah, she's got 2 videos up on CataractCoach. Yeah, she does some beautiful cases. Beautiful. And again, like you, like me, like all of us who are in practice, you have to be self-taught. The way you do surgery in 10 years is not the way you're going to do it today. And there will be new techniques and new technologies that you're going to have to learn solo. Today, before our video conference call, I actually was arranging to get certified on a new laser. Now, I don't do a lot of femto-phaco. We do have 2 femtos in our private surgery center. We actually just now got a 3rd. So I had to contact that company so I can do the official training and learn how to use it, because even though I may not use it all the time, I want to learn everything. I want to learn every device, every machine, every technology. Bring it. I'm here to learn.
Well, just make sure you wheel those machines nearby each other so they're not so lonely. You know?
Well,
if they never get turned on.
In our surgery, in our surgery center, luckily we have many surgeries. We have a huge surgery center.
Good.
Yeah, we have 7 ORs just for eyes in our private center.
Oh, wow. Holy cow.
Yeah. So it's a big center that does, 18,000 cataracts a year.
Oh, wow.
Yeah, so like I said, my dad didn't raise any lazy kids. Ugly, yes, but lazy, no. Now,
that's awesome.
In Iowa, now you're not originally from Iowa, are you?
No, I grew up in Alabama, and my father was in the Air Force, and so he was stationed at a base there.
Do me a favor, will you tilt your camera down just a little bit? I'm getting your
mouth.
Oh yeah,
yeah, sure.
Or sit, there you go. So you were in Alabama. Your father was in the Air Force.
So I grew up in Alabama. My father was in the Air Force, and they have a section of this base in Alabama that just does education, and he had a PhD in education, and so I learned a lot about sort of education in the Air Force, how to be efficient about it from him, and I think he was an inspiration to me. I know he was, and I learned interesting things like, I was in the Air Force myself too. So I was in the Air Force for 4 years myself. And one of the things that always sticks with me about the Air Force is you can take somebody right out of college.
Sure.
And in about a year and a half or 2 years,
become a pilot.
They're flying an F-22.
Yeah.
Right?
Yeah.
For us, it takes 8 years out of college before you're doing phaco.
Yes.
So that's ridiculous, right? I mean, I realize that we also have to learn billing, and that takes 3 or 4 years or whatever. But is it really that much harder to do cataract surgery than to fly an F-22?
Probably not.
I don't think so. So what the Air Force does so well is, first off, they totally focus on training. You're not doing anything else. You're training, and the teachers are not doing anything else. They're training. So it's not like the person that's teaching in the Air Force how to fly. It's a part-time job, the teaching.
That's all they're
not also flying missions to Afghanistan. They're focusing on teaching you when they're doing it.
Sure.
So, but the thing they're really good at is the things we were talking about earlier. That just very structured, stepwise training, doing things they know that you can excel at. And so anyway, that I think that was a big influence on me. Was my father in the Air Force, and then I was in engineering in the Air Force. And engineering is also very structured training.
So
right?
when you did your undergrad at Duke, you were a CSE, right? Computer Science, Electrical Engineering.
Right. And so when I got out of college, I worked in the Air Force as an engineer, as an electrical engineer, and so in engineering the training is much more sort of, learn this little thing and then learn the next little thing, and it builds and builds and builds and builds, and I was shocked when I went to med school at how disorganized it was and how poor the sort of training plan was, and it always seemed that whatever we learned about was the pet project of that professor. It didn't have anything to do with sort of our plan or our big picture. I mean, we had 3 days at Duke on the brown fat and the flying squirrel. And I never forget that. It was like, it's really interesting. These little squirrels, they have this brown fat, and it burns calories, and they never get fat. Have you ever seen a fat brown flying squirrel? No.
Probably not.
Because they have this fat in their body that just burns. But anyway, the point of that was just that it doesn't really help me that much to know that, and we spent 3 days on that, and so you sort of a top-down approach of sort of education is what's so efficient, where you line up the sort of your goals and objectives with your assessments, with your resources.
Sure.
If you line that all up, it's just like magic. One of the people that in ophthalmology that's really good at that whole idea, that concept, is Andy Lee.
Sure.
So I learned a lot from Andy Lee when he was here, and he's one of my real mentors in education. But anyway, he's a big believer in that, and I'm a big believer in that. But I think the Air Force and the educational stuff helped me quite a bit.
So then you did the Air Force then for 4 years. Then you went back to Duke, did a master's in engineering also.
Yeah, I was going to do a PhD in engineering. So I went back to Duke. I entered a PhD program, and then I got partially through it. But in the meantime, my wife was in med school, and I thought it was really cool what she was working on and doing. And so I
switched gears.
I switched gears.
How'd you fall into ophthalmology?
I guess like so many others, the technology was cool, the surgery was cool. It was combination of stuff. I was thinking about the usual other ones like ortho, urology, ENT.
Sure.
And I just thought it was really neat. It was very precise. Yeah, it was good. I'm very glad I did. I mean, it's such a, I'm sure you must be too. It's such a great field.
Oh, I'm thankful every day that I'm an ophthalmologist, every single day. Now I got a question for you. So yeah, now that it is such a long path, right? 8 years after college just to become an ophthalmologist, to do phaco on your own essentially. 8 years. Are we training enough ophthalmologists? The number of residency spots in America is held relatively constant, 460 or something a year. Are we training enough? And then a lot of people are going to choose to work part-time because they're smart and they figure out a work-life balance. Are we training enough surgeons?
We just went up one position here because there's such demand for our graduates.
So you're like 6 years now?
Six per year now.
Fantastic.
One of the things that I was on this committee that was sort of re-looking at the way we did the whole educational process, and we produced this white paper that ultimately resulted in sort of the national push for integrating the internship.
Sure.
But what at least I thought we should do, what we really were pushing for was to try to not only integrate the internship but get rid of the fellowships, and so the idea would be, you make medical school go to 3 years. You make the residency go from 4 years plus an internship plus a fellowship down to 4 years total, and so that you have some time in the residency that's selective, and you have some time you have much more time in the internship that's ophthalmology, and so that was our hope. It didn't kind of pan out that well. There's a lot of politics in the fellowships. 70% of ophthalmologists now do a fellowship. And yet there's so much market for comprehensive or for general ophthalmologists. There's a huge market for them. So if you could, and then a lot of times the fellowship is a lot about what that academic center needs to service their business.
Sure.
As opposed to what the person in the fellowship needs to go off and practice. You might you might do tons of crazy orbital stuff when in the reality is you're not going to do that when you get out, or very few people will do it. And so I don't think it's been very well thought out, and it's there's so many silos and so forth. It's very hard to argue that. But what we were hoping we could do is push more of the training into the internship of what's learned as an ophthalmologist, open up time in the final year, and have many fellowships.
Yeah. So for our listeners who aren't so involved in academic ophthalmology, what's happened is, just even a few years ago, you did two applications as a senior in med school. You did an ophthalmology match, which was sort of PGY 234, and at the same time, you did a regular match for your internship, was PGY 1, which is separate. So now, as of this year, they're all integrated. So all programs in the country for ophthalmology residency are now 4 years, PGY 1, 2, 3, and 4. And that 1 year internship, instead of being 12 months of surgery or medicine or whatever else, or rotating or transitional, it's usually 3 or more months of ophthalmology, and then let's say 9 or less months of the rest of medicine. And so it gives you a few more months, so that now that PGY2s are coming to you, they already have at least 3 months of experience, so they can kind of hit the ground running. I think that's a smart move. I think Iowa's really pioneered the field in that way, and it's to the point where like every residency in the country now switched to this. I think it's a great move, actually.
Well, we once again, we stole it from Utah, and the reason we got the idea was we had some residents that had done the Utah internship.
Sure.
And then they came and did ours,
and they knew.
They were so far ahead of everybody else.
Yeah.
Norm Zabriskie was the one. I don't know if you know Norm.
Haven't met him.
He's a cool guy at Utah. But anyway, these fellas were so far ahead of everybody else that we said we why don't we do that? And it's been a really important thing in our residency program. However, I think nationally that it should be more than 3 months of the internship for ophthalmology. It should be like 6 months or something like that. It shouldn't just be 3. But that's a big political battle.
The other challenge too, though, is I think back to when I did residency. I finished in the year 2000. Residents today have to learn everything I learned, plus all the stuff that didn't exist. There was no anti-VEGF, there was no small gauge vitrectomy, there was no OCT machine. It was a different world. And they're learning that plus what I learned in the same amount of time.
And they're busier.
Yes.
Probably. It was a big deal if you did 150 surgeries when I got out, and now they're routinely doing
300,
250, 300,
yeah,
and
for sure.
And there's just as many stupid notes as we had for each one of those, maybe more, right?
Or even the thing that didn't exist then that's just huge now is like I think every resident finishes with thousands of intravitreal injections.
Yes,
literally
yes,
thousands.
Yes, and that's true. That's a whole new thing, and. But anyway, I there's no doubt the residency's harder now. I'm convinced it's harder than it was, or at least at the very least it's different. It's not easier.
I know for sure. There are a lot more challenges. I think another thing we don't ever talk about is when your residents finish all this training, all this sacrifice, and now more than ever, if you look at your application for residency, up until last year I was on the residency selection committee for UCLA for the Jules Stein Eye Institute for many years. The number of applicants with additional 1 year extra research during med school, another 2 years they did a master's degree, the number of MD PhDs like Andy Doan, extra 3-4 years for a PhD. You keep just adding on all these extra years, and at some point you're like, wait a minute, these guys are making a humongous sacrifice in their lives and kind of delaying getting into practice and taking care of patients and honestly living their own lives and taking care of themselves and their families.
Yeah, it's I totally agree with you. It's gotten out of hand. There's all these really unbelievably qualified people that are coming into medical school and coming into our residency programs, and then this is the sad part. is we squish them and we crush them and we try to press them into the form that everybody else is.
Yeah.
And that. Not every program does that. I'm not saying every program does that, but it's a real problem. You know, you bring in these amazing people, and then you don't care about all their amazing parts while they're with us. Now we started something. This is related to watching my children, how they were treated. None of my children went into medicine. So 2 of my children went into sort of high-tech finance kind of worlds, and they work hard, but they're totally respected.
Yeah.
You know, and their ideas are valued, and you know they're well taken care of. You know, they have benefits and snacks and you know, bring in lunch for them, that kind of stuff. But
not us.
Not us. But what I really noticed is just the way that they were valued.
Yeah.
As young people. So what we started a few years ago was this thing called Captain of Your Ship Time. And I think it's been really transformative to our program. But basically the idea is very simple. You get a half day every other week, and you can do whatever you want with it.
Oh, nice.
And so the
fantastic.
idea, yeah, and we don't care. We don't ask you what you do. We don't care.
Just do it.
Just do it. And so you can go to the gym. You can sleep in. You can hang out with your family. You can do counseling. You can work on projects. And we've had some amazing projects come out of that time. And it's projects that you can't do at night because you have to interact with other people.
Sure.
The best project was one of the best projects was this woman, Lauren Hawk, who's now a professor at Wills. And this was tangled up with Dr. Glockenflecken. But basically,
Will Flannery.
Will Flannery.
Yeah.
So I'll make the story as quick as possible.
No, take your time. We're here to enjoy.
Basically, Will Flannery was on consult with Lori Provencher.
Okay.
And the patient they were seeing was just totally, incessantly hassling Lori Provencher.
Okay.
You know, oh, your hair's nice or whatever, you know, just stupid stuff like
Okay.
that. So Will was shocked by this because it's uncommon that you go in and do a consult with somebody else, right?
Sure.
So, but he was shocked at 2 things. One was this was happening, but the other was how Lori just didn't care. She just moved on her job and did it. You know, like it's like whatever. You know, I'm not worried about this. This is something I have to deal with. This is part of the overhead of my life. You know. So, Will with iSteve's help, wrote this unbelievable blog that you can still look up called "There's No Such Thing as a Lady Doc."
Okay.
And Will wrote this, and it was a great sort of idea of sort of, you know, from a patient point of view, don't hassle these amazing women that we have in our programs. And then iSteve put it on his site, and then iSteve arranged for it to sort of go viral. He figured out, and it was like in the top 10 medical blog posts in the year it came out.
Wow.
So that's the background. And so we knew we had a problem, and we started talking about it a little bit. And then this woman, Lauren Hawk, just took the bull by the horns with another woman, Brittany Scruggs, and they came up with like a scale for harassment by patients of our doctors, primarily of women doctors, and produced talks which are now available on courses which are available. It was picked up by nationally. It was picked up by everybody in the hospital. It was picked up by the by the AAO. And all this was done because she had this half day.
Wow, that's neat.
And we didn't know exactly what she was doing, and then all of a sudden she came out with it. And because probably at first she wasn't sure if it was okay, or kosher or whatever.
I may have to contact her and interview her for the podcast. That sounds amazing.
You should. Her name is Lauren Hawk, HSCK, and she's a glaucoma professor at Wills.
Listen.
Super cool
I
lady.
get the struggles that women have in our field or in any field of medicine. My 3 sisters are doctors. My mom's a doctor. My mom's mom is a doctor. My daughter's in med school. I totally get it.
Yeah.
So I've heard this growing up my whole time. And so, no, that'd be a fantastic topic to cover.
The interesting thing from my point of view is I used to hear this stuff, and I wasn't sure what I was supposed to do.
Yeah.
You know, and now I know exactly what you're supposed to do. But I used to think, well, if I intervene in some way, it's going to be patronizing and going to make the situation worse.
So what's your move?
In my opinion, the thing is you jump right in from the very beginning, and you hear this, and I enjoy it now. I almost look for it. It's like I revel in it. As soon as I hear that, they'll say, nice hair, you have nice hair, doctor, or whatever. And I'll say, boom, Dr. Hawk is one of the most amazing doctors we ever had here. Sure. We recruited her from, Clemson, and she's been an amazing doctor. She's done all these things. She's one of the most qualified doctors in the world. We need to focus on that. And as soon as you do that, the patient realizes, okay,
change gears.
And it's not the patients are evil. They're just not sure what to do.
Yeah.
And a lot of them are, they're these old goobers like me, they're not sure exactly what to do in this modern world, whatever. And so, but all you need to do is help them, help train them, and stop it from accelerating to the point where people are mad at each other. And that's what Lauren
That's smart. That's really smart.
Was telling us is that you intervene early and simply, and then if you're by yourself, she has some strategies for it too. But yeah, I would totally encourage you. She's also one of the most articulate people you'll ever meet. So,
that'd be fantastic. So, what is the future of ophthalmology? What do we? So, I did a podcast just 2 weeks ago with young residents. Of our UCLA residents, we have 8 a year, and this year 5 out of 8 are actually going into practice and not doing fellowship. And actually, I'm happy to say that in the last many years, we've kind of shifted the gears here. So UCLA residents in general are much less than that 70% going into fellowship number. But what's the future? What's our future of ophthalmology? What do we pass for these guys?
Yeah, I mean, I think it's funny. We've noticed that a little bit too. We've got this year. We've got 2 that are going to practice. Not doing a fellowship. I think
to be honest, you and I neither. I didn't do a fellowship. You didn't do one either.
Yeah.
I do a fellowship every day by making CataractCoach videos.
Yeah. There's certain silos that kind of fit and certain that don't. But to me, I think the obvious sort of need, in my opinion, is more training in the area of sort of refractive cataract surgery.
Yeah,
that's the area where I feel like we're letting our residents down a little bit here, and where we're trying to get better and better. And so one of the things we've done is we've set up a deal where our residents can go briefly to Vance Thompson Vision, which is one of the sort of meccas of that in our world of make believe.
Yeah.
But I think I really feel like that's an area of concern of mine that because in order to sort of take people through the training and have the training wheels on, you get to a point where they can do that, but we're not accelerating fast enough to get to the point where they can do that while they're still here.
Sure.
Now I've told you we got an extra resident. We've shifted things more into the intern year, and so we're going to have a big elective in about 2 years. We're going to have a giant elective in our last year.
Oh, for refractive cataract surgery.
Yeah, and so that's going to be our thing, and we need you to get your act together, get your daughter graduated from medical school, and come here and take it over. That's what we need. But I think
my kids are smart. You know why? Because they don't listen to me. So don't worry. They'll never do whatever I say.
Well, I just want you to have enough money to send her to med school, and then you can come here.
Okay, deal. She's there. I'm paying the tuition. No problem. With a smile on my face. But I think that's a smart move. That's where we're headed. There's a statistic that if you look at very carefully, in 1987, 66982 or 66984 regular cataract surgery paid $3,200 in 1987 dollars. In the year 2000, when I finished residency, it was about $1,100 in the year 2000 dollars. Now it's sub $500 in year 2023 dollars, which are very devalued. And another way of putting this was, In 1987, you had to do 3 cataracts to buy a base Ford F-150 pickup truck. And in the year 2000, you had to do 18 cataracts to buy that base F-150 pickup truck. And the year 2023, you have to do 82 cataracts to buy the same base F-150 Ford pickup truck.
Yeah, that's a great way of looking at it. I love that. I love that way of looking at it because, our services as cataract have been devalued, and not only that, the other services have not been similarly devalued, and so things like dry eye become interesting.
Yeah, but this. When I tell patients, I said, cataract surgery, how important is it? It is so important that this surgery is going to change the way you see the world every waking moment for the rest of your life. That's how important it is.
Well, it's to me. It's if you throw away the financial part of it,
sure.
There is no better sort of crazy magic trick in the world than this, right?
You get a patient with a white cataract, the next day they could be normal vision. That's like magic in a 10-minute surgery. That's magic.
Yeah. The only thing I will say is, what struck me over the time is you take somebody that's got a white cataract and you make them 20/20, and they'll say, well, it's not quite perfect. You take somebody that's got bad macular degeneration and you take them from count tall buildings to count regular buildings.
And they're like, oh my God, I'm so happy.
They're like, this is great. This is the greatest thing in the world. And so that's one of the things I learned from Mark Wilkinson, who's one of our optometrists here, is because we would sometimes forget about those people.
Yeah, for sure.
And those are some of the happiest people.
Yeah, for sure.
Those people.
Listen, just come to Beverly Hills sometime. Oh my goodness. I've had patients who are Plano minus a half at 90 and say, but when's it going to be sharp?
Yeah.
And they start off 2,200.
Yeah. Well, they're lucky they've got you. I'll be glad to come there and tell them.
Oh, a patient told me, she says, doctor, very, very fancy patients, but very fancy. She said, doctor, of all my service personnel, you and my chef are my favorites.
You and my dog walker.
I said even better. I said, that must be one heck of a chef.
You must have Chef Bobby Flay.
You got something. There you go. Come in full swing. You got something. But no, it's a different world. That's why, honestly, my reprieve used to be going to the county hospital, where the patients are so thankful. They have such bad disease, such complicated disease, and they're just so appreciative of any improvement in vision.
Yeah. Well, it's a hard business you're in, but I think to have demanding patients, but it makes you good.
Yeah, it makes you good, and you step up to the challenge. But I think you're right. I think that's a smart move. That's a brilliant move, because arguably, if you're a cataract surgeon in practice, that's probably a larger portion of what you do is that refractive component of the cataract surgery, astigmatic management of whether it's toric lens or incisions or LRIs, or doing choosing appropriate refractive targets, extended depth of field lenses, trifocal lenses, all these things. I actually I used to do a lot of ophthalmic consulting back in the day. And in 2007, I had the companies donate free of the presbyopic IOLs, the old crystal lens, the original Restore, and the array, the zoom lens. No, the zoom lens was the one after the array. They donated these lenses for our county hospital patients to have.
That's great.
And it was like, we taught residents how to do it in 2007. So I hope someone, at least at UCLA, learns from you and picks up that idea of like, hey, let's integrate a refractive component of this. I think it's a super important part.
We have this wonderful arrangement with Alcon where they will let our residents have premium lenses for free.
Yeah.
And we did a really funny study. So the study is something like this. We had 100 consecutive patients where I asked the patient, I said, our chief resident you just met can do your surgery and the toric lens is free. Or I can do it and the toric lens is $1,000 or whatever it was.
Yeah.
And the whole time I'm secretly hoping that they're going to pick me. I want them to pick me.
Oh, there's no way.
Yeah, no. There's 97 out of 100 pick the resident, and 3. So I figured my net value was something like, I don't know, $16 or something is the value. the reason I say that is I just want you to realize that this is the true metric, and it helps with training.
Sure.
Because you realize that you're not worth as much as you think. At least I'm not worth as much as I think. Now they probably would have picked you instead of the resident. I don't know, but the other thing is, if you can offer that in the training program, it does give confidence to the residents. And the VA, of course, it's free. So
sure.
every program that has a VA, the VAs all stock torics, and some VAs stock multifocals.
When your residents are in training, do you have them exposed to everything too? All the MIGS devices, femto, zepto, this, that, the other? Do you try to get them full exposure? Do your residents do? I got a question. Do your residents do LASIK as residents?
They do a very few LASIKs. Our residents, they don't have a good exposure. The programs that have the best exposure to LASIK are those that are connected with a military facility.
Sure, of course.
But our residents are competent and they become certified. But not all. No, we've never, to my knowledge, had a Zepto here. It's an interesting device. We don't have a femto, so they have no exposure to that.
So already, when they go into practice, they're going to have to do what I'm doing. Sign up with do the training program for this new, for our third femto, which again, I probably won't use that often, but still I'll do the training for. But they have to take some responsibility. When you start your practice or join your group, you got to keep learning.
Well, it sounds like you could send us the femto, you wouldn't even miss it.
No, you can have. Well, I know other surgeons like it.
You could send us the femto and you would say, "Oh my God, what happened to the femto 3 months from now?"
Yeah, no, I think other surgeons like it a lot, so who knows? But,
I'm just teasing. But
that's another important topic is that, listen, there's no one right or wrong way to do a cataract. There's so many different techniques, so many different devices, so many different lens choices that you can't just say, okay, this is the exact way. Only do it this way. That doesn't exist.
There's the program. There's a couple programs that have really integrated the femto in well. Wisconsin has done a really good job with that. They have a femto. They were one of the few VAs that got a femto.
Okay.
That they early adopted, and before the VA came out eventually with a policy that femto was not better, and so nobody else could get them after that. But they committed to the femto, and so you could talk to them about that if you want to get their experience. And then Wills has a really good experience with femto, with resident training. Yeah,
both fantastic places. But yeah, I think it's not that critical. And then even LASIK, when I was a resident, I was very fortunate, the first resident to do LASIK at UCLA back in 1998 or 9. I only did 4 eyes, but that was enough. And so that you give you the taste of it, so you say, I have a thirst or a desire to learn more. So I think even if your residents do just a couple or a handful, and I think our UCLA residents today only do a handful of LASIK as primary surgeon, that's enough to give them that drive or that taste, if they desire, to go out there and just keep learning, keep doing it. But I think it's just, you've got to make the commitment as a young doctor when you start practice. I am going to keep learning every single day the rest of my career. And I think that's how you stay good.
If you Google "she don't need no femto laser," I put out this video for Essie Hong, who is a resident of ours. She was applying for a job at Kaiser up in the Bay Area.
Okay.
And she had just come off this deliberate practice with Dr. Johnson, and she had just did 100 of these cases, and she was at our VA hospital, and she was just cranking out these perfect rexi one after another, and so I she don't need no femto laser, to Pink Floyd, anyway, that video, my oldest son did the words for it, but it was sort of an attempt to get at that point, from the point of training. But I do think it'd be a lot easier for me to say, if I came from a position of power where I had a femto laser, sure, and could really say that it's not that important. I can't do that because I'm so biased by not having one, Don't
worry, I have access to 3, and I can tell you, it does not make you a better surgeon. It's not that critical, and I don't see, in 99+% of cases, I see no big benefit. I just don't.
Well, that's a much more powerful statement, because you've sucked up the overhead for that, and But anyway, I think from the point of view of training, it's nice to know how to do Orexis. And,
For sure. I've been having such a fun time talking to you. It's been a long time. I want to end.
It has been a while. I'm sorry.
No, we're having a great time. I want to end by two things. Number one, I want to ask you, what are the best decisions you think of your career? And then I want to know what you do for fun outside of ophthalmology when you're not making cataract surgery stuff.
Yeah. So, I think the best decision, honestly, I made was to go into academics. I was in private practice briefly after residency, and it was just at the beginning of having comprehensive people in faculties.
Sure.
Because that was a new thing. Because why would you have a comprehensive person? And the only reason they started doing that was because of the billing changes with Medicare.
Sure.
And so I thought I'll give it a try. And I sort of had a chip on my shoulder because I didn't think that our VA was as good as it could be. And as I mentioned, I was a veteran. And I didn't think the cataract surgery training was as good as it could be. And so I had this chip on my shoulder. And I thought, well, I'll just go for a couple of years. And I applied to a couple places. And fortunately, I ended up at Iowa. And the weird thing, the only reason I ended up at Iowa was because Dr. Miller Meeks, who's now in the House of Representatives, left the job that I took. And so I was just lucky that she got bored by it and moved on to something else. And so anyway, I think that was the risk I took because in those days, comprehensive ophthalmologists weren't common in practice, in academic practice, and they were considered sort of second-class citizens, maybe to a certain extent still are. But and that was risky.
Sure.
And so I think that was a good decision. And coming here was really, but I knew it well, but it was really good. Having my chairman, Keith Carter, support me was really good. And I was lucky to have guys like Andy Lee and Lee Allward and Johnson, I mentioned, all those other people that helped me. So I think that was good. The honest truth about what I do for fun, I'll do for fun whatever might allow me to spend time with my kids.
I'm the same way. You're too funny. Now that they're grown, right? Grown and gone.
Yeah.
You just want to spend time with them.
Yeah. I'll like my one son likes to pheasant hunt and fish and stuff, and so I never taught him how to do that, but he picked it up from and I'll just do that if that helps. Or my kids like to play pickleball, and I'll play pickleball, even though it's seriously at risk of pulling things, and injuring things.
But just so you can spend time with them, so you can do things together.
Yeah, it doesn't matter what it is. My youngest son is just a wonderful student of art history, and so. I'll go to these museums. I'll look a little bit before I go to the snack bar area. I'll actually look at a few paintings with them.
Sure.
But it's just time.
Yeah.
I just want time with them, and honestly, that's all. That's really my focus. To be honest with you.
Oh, that's fantastic. Well, Tom, I loved this interview. I had so much fun talking to you. I'm sure this is going to be a very popular podcast. We'll have it up on Cataract Coach at the end of February.
Well, I really appreciate it. I just want to thank you again on behalf of the whole Iowa team for doing your videos, which are so amazing, for all of the dedication to teaching, for agreeing to come here in June, for Dr. Johnson's goodbye, and for your friendship and your support over the years. I really appreciate it.
Oh, my pleasure. And when I come out there, if the budget doesn't allow all the residents to come to dinner, I'll pay it. Do not worry.
All right, good. Well, they'll be glad to hear that. They'll probably be listening in. Thank you very much.
Life is short. You got to enjoy it every day. All right, thanks, Tom. I really appreciate it.
Hey, take care, Aaron. We'll see you.
Thank you for enjoying that podcast with me. I trust that you learned a lot and really got into that deep conversation in these topics of ophthalmic surgery that are so important to us. We're going to have many more podcasts in the future featuring all kinds of people in the ophthalmology space, from beginning ophthalmologists to experienced ones and people in the industry. And we're all going to learn so much together. I encourage you to go to Apple, Amazon, Google, Spotify, or wherever else you find your podcast. Sign up, subscribe, download the podcast, and I look forward to next time.